crawl out of the dark of our clinics and into the light of the broader realm of pediatrics. We appreciate you keeping the lights dim in here for us. That's very helpful. My name is Ray Ario. I'm the medical director of the Minnesota Lions Children's Eye Clinic, which is right across the street in the Park Plaza building on the 3rd floor. If you guys have never been, if you ever want to come over and kind of see what we do in our facilities and meet everyone, you guys are welcome anytime. Shoot me an email, and I'd love to show you around. So I'm just going to talk briefly about our team here. We have, at this point, 5 MDs working with us and 1 full-time pediatric optometrist. And we all sort of have our own niche. Jill, we all see the spectrum of pediatric ophthalmology problems, but Jill Anderson also is our retinoblastoma specialist. I do complicated pediatric glaucoma and anterior segment surgery in kids. Keith Engel and Gail Summers, Gail's our division director, work together on our genetics eye service and see kids with retinal dystrophies and other complicated genetic ocular disorders. And Dr. Strul, who just joined us, also has an interest in many things in pediatric ophthalmology, but among them is pediatric diabetes, and she's going to talk to you guys about that today. So, and then Sarah Downs is our full-time pediatric optometrist. We also have 3 orthoptists who are sort of like our mid-level providers in pediatric ophthalmology. They see patients, they work up patients for us, they see some routine follow-ups, and we don't really need to be involved for tweaking some glasses or patching therapy. And then we also have residents and fellows and a research team. So I'm really up here today to introduce Dr. Strul. We're really excited. Sasha joined us just this last month and a half or so. And Sasha's originally from Florida. She did her MD, her BS and her MD down at the University of Florida, and then went out to Colorado for a year to do her transitional internship before going back to ophthalmology residency in Florida. She was in Nashville for a year last year doing her fellowship in pediatric ophthalmology and strabismus, and she just joined us a month and a half ago as our newest member in our department, and we were really excited she's here. I know some of you have said, gee, we wish we had a little more access, and now we have a little more access, so we're really excited. Sasha is here every week. She also goes to Burnsville every week as well, so if any of you have patients from the South area who need a pediatric ophthalmologist, it's sort of a, unfortunately, little known fact sometimes that we have a clinic there at the Fairview Ridges site. So, so Sasha's there every week and would love to see your patients. So, and Sasha does do adult strabismus as well, but the majority of her practice is pediatric ophthalmology. She also does anterior segment surgery, takes care of kids with uveitis. And like I said, today she's going to talk to you a little bit about what she's working on in pediatric endocrinology from a vision standpoint. So with that, I'll turn it over to Sasha. Thanks for having us.
All right, can you guys hear me? All right, great. So thank you, Ray, for introducing me. I'm really excited to be here this morning. As Ray said, I just recently started in October seeing patients here, and I'm excited today to actually talk about something that's near and dear to my heart after being a fellow over at Vanderbilt Medical Center at Tennessee. And today I'll be talking about pediatric diabetic retinopathy as well as telemedicine for this. And so I have no financial disclosures for this talk of interest. If anybody has any for me, let me know. Diabetes in the U.S. is what I really want to start out with. I want us to take a step back from such a niche and very specific topic of pediatric diabetes to really state what is going on in the U.S. today as a whole. So we have over 30 million patients who are undiagnosed or diagnosed with diabetes who are actually living with this. And of this number, we actually know that about 200,000 of them are under the age of 20. And so this is a big issue. We actually know that patients who are not diagnosed will have more complications in the long term, and this is something we really need to focus on. When you look at the map that the CDC put out, if you look at Minnesota, we're actually doing a lot better than some other states, but we still have a long way to go. So the incidence of diagnosed diabetes in this group is actually estimated to be about 3.8%. And if you look at the self-reported vision loss in this group, which is of course very important and what we'll be talking a bit about today. Now this is adult data from 2013, but up to 8% of patients actually felt that they were suffering from vision impairment related to their diabetes. And that's here in our home state. When it comes to pediatric diabetes, our epidemiology is a little bit lagging. I'm very thankful to report that the Search for Diabetes in Youth study has actually helped us catch up quite a bit in our understanding about the natural history and prevalence of diabetes in our children, but it actually is still something that we have a little bit of a black box on. The study, the Search for Diabetes in Youth study, actually was out of 6 centers across the U.S. So it was only 6 centers, but across the United States, and they actually looked for the prevalence in 2002 and then how that changed over the next 10 years. So in 2002, there was about 1.82 cases per 1,000 youth overall, and that increased over the next 10 years. So unfortunately, that means that type 1 diabetes diagnosis increased at a rate of about 1.4% per year, and type 2 diabetes, which we used to classically be taught was only in adults, right, is now being an increasing rate of 7% in youths, and that's a huge jump. Diabetes in the eye is the reason why I'm here today. A lot of people in this room take care of kids with diabetes for different reasons, whether it's from an endocrinology standpoint or for other complications. But the diabetes and eye situation that we deal with is actually a very important one too, and I'm going to be speaking from it as a pediatric ophthalmologist perspective. And it's really important to understand that while we're focusing on diabetic retinopathy, there's lots of things that influence vision and can impact these patients. And so whether it's transient blurred vision from induced nearsightedness as sorbitol enters the lens and actually causes it to swell when there's that sugar spike, or if it's cataract development, which in young adults can actually become a little bit earlier on, so they might develop cataracts at age 50 instead of 70, or as I've seen and many other pediatric ophthalmologists have seen, you can even see a 15-year-old or even younger diabetic who's poorly controlled or didn't even know that they had diabetes, who come in with sudden onset rapid progression of cataracts. The picture here that shows a snowflake cataract, while really pretty and very cool, is very rare to see. More commonly, you're going to see a very white cataract, which is important because while this might limit vision to some extent, a white cataract can take you from good vision to just seeing hand motion overnight. And so that can be reversed by doing surgery, but long-term, what's going to keep these patients seeing is controlling and preventing diabetic retinopathy. So even if you take out their cataracts, you control their blood sugar spikes, you really need to prevent the retinopathy to prevent blindness. So diabetic retinopathy. At this point, we know, as the WHO has made it a priority disease to tackle in the coming future, about legal blindness in the world for working-age patients is actually one of the #1 causes. And we know that 7% of people with diabetes are at risk lifelong for blindness from this disease. By about 7 years into your diagnosis with diabetes, 50% of patients will have some level of diabetic retinopathy. That can range from something that's mild to something that's vision-threatening. And it's worse if you have type 1 diabetes, in that 90% of patients by 15 years will have this. And if it's type 1 diabetes, it's more likely to be a more severe retinopathy. So what is diabetic retinopathy, right? We're talking about it. What does it actually mean? What do we actually look at? And what are we actually looking for in our patients? Well, I like to go back to history. I'm a little bit of a history of medicine person. And I like to think about some of the really amazing advances that happened in the 1800s for ophthalmology. Something that all of us potentially use in our office, the direct ophthalmoscope, was actually invented in 1855. And Edward Jaeger, who was an Austrian ophthalmologist, thought, hey, this is cool. I'll start looking at some diabetic patients who complain of vision issues and see what I can see. And amazingly, he was able to really see diabetic retinopathy, and he was the first to describe it. He described yellow-white spots, almost like an exudative process, which he then drew the first ever known picture of diabetic retinopathy. And he was pretty spot on. So I love this comparison. This is actually a picture from the program on telemedicine I'll be talking about today. And you can see that his picture, which is beautiful and epic, I don't think I could ever draw that well, but he actually did a really good job. And so diabetic retinopathy is really a disease of blood vessels. And so what he picked up on was the exudates, and that's from leaking blood vessels into the retina. The retina is the film part of the camera of the eye, and it's very important that we don't have swelling, we don't have blood spots, and then we actually get good blood flow to the retina. We have such fine vessels there that if they become blocked, we get ischemia and tissue loss. And this is a main cause of diabetic retinopathy, vision loss. We also see swelling, which can sometimes be reversed and sometimes not, but we can also see progression to scarring and even tractional retinal detachments or glaucoma. In order to try and prevent this and actually treat patients in a timely manner, multiple organizations have come up with screening guidelines. One of the main screening guidelines we as ophthalmologists use is the American Academy of Ophthalmology screening guidelines, which talk about type 1 diabetics needing screening after 5 years of their diagnosis, whereas the American Diabetes Association recommends it after age 10 or after 3 to 5 years of diabetes duration. Both agree that annual exams should start right away for type 2 diabetics. When we look at telemedicine and how this has actually helped, we can look at examples across the board. I actually chose to pull this from the VA. This is 2015 because they actually implemented a telemedicine screening program instead of the standard ophthalmic exams and found good success. And we're hearing this across the board. And so while screening guidelines were originally created for dilated fundus exams, telescreening for diabetic retinopathy has been very successful. It's actually improved access to care and reduced time and cost associated with an ophthalmology clinic visit. When we look at telemedicine for pediatric diabetic retinopathy, back at Vanderbilt, we actually decided to start a program in December of 2015 to try and improve access, and our goal was to truly improve compliance and prevent vision loss for these patients. What we did is we actually linked a photograph that was acquired during a clinic visit at their endocrinology clinic. We actually linked that to their visit that day, and then we actually had somebody come and actually remotely recognize if this is something that's abnormal or normal. We did this with a non-dilated camera. What that means is that no drops. So while we don't do shots, our big fear for a lot of patients is actually the drops, and there's no drops needed for this. And all the photos that you're going to see, unless they're tagged with a certain citation, are actually from the study photos. So these are all non-dilated photos that are taken, not by an ophthalmology provider, not by an ophthalmic photographer, not by a general photographer, but by a nurse who was able to take it at the endocrinology visit that day. So the provider says, you meet screening diagnosis at this point to need an eye exam. Let's go ahead and get a photo today and send that off to our ophthalmologist who's off-site, and let's see what they say if we need to have a full exam. So we started this in December of 2015, like I said. These are 45-degree photos, so it's obviously not the full back of the eye, but actually gives you the center of vision, which is the macula here, the optic nerve, and the vessels over here. So what did we find? Well, from December 2015 to May of 2017, we actually screened 852 youths, and that was determined not by us as ophthalmologists, but by the endocrinology providers. So it's really them who were driving the boat and saying, you know what, you've had diabetes for over 10 years, you've met criteria, over 10 years of age, or you've had it for over 3 years, you've met criteria for a type 1 diabetic or at the diagnosis of type 2. They also tried to play catch-up for a lot of patients as this was a new program. So many patients who should have already been screened were screened potentially for the first time with this program. We found 52 abnormal patients, and we also compared this to figure out is there some difference between the groups who actually had abnormal screens and those who were normal to see if there was a difference between them. We actually took a sample of the randomly from the normal group of 64 patients. We found our prevalence of diabetic retinopathy in our cohort to be 6%. So I took out a little bit of what we did. We looked at average A1C in the past year. We also looked at the type of diabetes between the two groups, how long they've had the diagnosis, their age, their gender, their race, if they were Hispanic or not Hispanic, and if they were Medicaid or not Medicaid, as well as their blood pressure, and as well as compliance with visits, both teaching visits that were not with an MD, which is held at the endocrinology clinic, or with their MD visits. I've pulled out some of the data that you can see over here on this side that shows that we actually looked at the significant difference between the two groups, and we found the distribution of age, the duration and type of diabetes within each cohort, as well as the average A1C within the year prior to screening were statistically significantly different. Patients with diabetic retinopathy were older, they had a history of longer duration of diabetes, all had type 1 diabetes, and had a higher average A1C in the year prior to screening. There was no statistical difference by gender, race, ethnicity, blood pressure, or even compliance, as well as their type of insurance. So the longer duration of diabetes, we know that that's a classic historical fact for having a risk factor for diabetic retinopathy. You can see that when we did our logistic regression, we actually found that independently, when we adjust for controlling for things like gender and age, as well as average A1C and duration, independently, the duration of diabetes, and the higher average A1C still hold true to be a risk factor for this. And this translates to the fact that if you have a 1-point increase in your A1C within our two groups, you're at 25% increased risk of having that abnormal screen, meaning that you had some evidence of diabetic retinopathy. The same holds true for the duration. If you had 1 year longer duration of having diabetes, you're at about a 17% risk for having an abnormal screen. I wanted to show you guys some of what the photos and seeing the range in what we actually see when we look at these patients' photos. So these are all, again, pulled from the actual study, and these are what our ophthalmologists actually got remotely in the electronic records. I'm showing you one eye, but normally, of course, we do take pictures of both eyes. And you can see here, if you looked at our first starting slides of normal, when I pointed out to you the optic nerve, the retina, as well as the macula and the fovea, this one looks pretty clean on first glance. But the miracle of our electronic health records, we can zoom in, and you can see there's really subtle, but very much so present blood hemorrhages right in the retina. And so that's actually an abnormal screen. This one here, if you're starting to pick up and trying to be savvy, you might notice that there's this one tiny microaneurysm right near the center of vision. So even though it's one single one, it does count as an abnormal screen, and it's important with the relationship how close it is to the center of vision. This is the other extreme. This is a patient who I really wanted to highlight to show the importance of getting these kids screened in time. This patient is a 20-year-old. She had type 1 diabetes. She was diagnosed at 14 months of age, and she was poorly controlled. She was also poorly compliant with eye exams. She came in and had these photos done, and she was motivated to come and actually follow up with us in clinic, at which point we confirmed the findings here of really severe diabetic retinopathy. She actually had progressed already to the stage of diabetic retinopathy that we term proliferative. And proliferative diabetic retinopathy is not a very kind form of diabetic retinopathy. And so when she presented, she had a best corrected vision of 20/50 in the right eye, this one here, and 20/40 in the left eye. She actually had neovascularization of the disc. So remember, we were talking about new and abnormal blood vessels. So we actually talk about it being on the optic nerve or elsewhere in the retina. And you can see these changes here that were early scarring as well as exudates and lots of blood hemorrhages throughout. She unfortunately also had ischemia of the retina at that time that was affecting her vision, and she required both laser therapy and injections in both eyes. Unfortunately, even with the standard care of treatment and prompt timely referral, I believe she was referred within 9 days of these photos being taken. She continued to progress and developed attractional detachment and has since had to undergo surgery. So she's at 20 dealing with something that we hope none of our patients have to deal with, right? So I really want us to talk a little bit also about what information we have about how patients progress to proliferative and other severe forms of diabetic retinopathy and why this is so key. So the Wisconsin epidemiologic study of diabetic retinopathy looked at 25-year progression of this, and they found that for patients with type 1 diabetes, so really a specific subset, which we found were our patients who had diabetic retinopathy on screening, under the age of 30, had progression of diabetic retinopathy of 83%. So 83% of patients would have some progression from maybe that mild background to progress onward. This was actually more severe if proliferative diabetic retinopathy in 42% of patients. So that last patient I showed you had the proliferative type, and those patients we actually found in 25 years for under the age of 30, 42% of patients actually progressed to that stage. Diabetic retinopathy was also associated with increased risk of life-threatening issues such as myocardial infarction and stroke in these patients, and that was actually correlated not only to having diabetic retinopathy, but having more severe forms of diabetic retinopathy. So as we were talking about, that 42% with proliferative diabetic retinopathy are at higher risk for life-threatening events. Compliance is a big issue when we're talking about taking care of these patients, whether it's controlling blood sugar or having them actually come to an ophthalmologist, right? And so we actually had the CAD study who looked at 316 persons. It's not a perfect study, it was a survey-based, but it really helped us to get insight into what was holding up eye exams compliance. And so not surprisingly, like you might hear about other issues for transportation or cost, those were the big barriers to success in compliance. Lack of insurance, or even just the misconception regarding access. They didn't think that it was a possibility to get the eye exam close to home, or they weren't sure if their insurance covered it, or even just not understanding the importance of it, not doing a good enough job of education. So what can we do at this point, and what did we find with our study? Well, I'd like to argue that the diabetic retinopathy of 6% is actually a little bit of a higher percentage. We'll talk a little bit about that. We also confirmed the known risk factors of being a type 1 diabetic, having a higher than average A1C, and having longer duration of diabetes. We also found that higher prevalence compared to other studies. I didn't go into detail about it, but basically a lot of studies have been showing, maybe we don't need to be screening such young kids because there's not usually this big, actually visually threatening diabetic retinopathy. It's extremely rare. A lot of the studies that I found that, such as Galanic in 2005, looked at patients who were a little bit younger than our cohort. They also have had studies out of Alabama that showed 4% of diabetic retinopathy, so a little bit lower than ours, but those had an average duration of diabetes of 5.5 years. So right when you start picking things up, and so ours was a little bit longer. We also decreased the number of patients who would actually meet screening guidelines who would need to comply with a second visit. So those kids who actually came to their endocrinology visit and had a screening exam, not all of them actually needed to have a follow-up exam with us. So it actually saved 90% of patients from having to go and see an ophthalmologist. I really feel that telemedicine has the potential to catch disease, as you saw, before they progress to that patient's level that we saw with the 20-year-old with proliferative diabetic retinopathy. I also want to highlight that just recently we had our annual meeting in New Orleans where a group of ophthalmologists got together and talked about the booming telemedicine field for diabetic retinopathy. And they discussed not only that it was cost-effective and successful in being implemented in both urban and rural situations in the developing world as well as the developed world, and that the image acquisition at primary care or other community settings can actually expand the access. But they talked about that maybe it's not enough. So even though it's fantastic and it's something that can really make a difference, there's concern that if we don't establish this now, we're not going to be able to catch up with the boom of diabetes in our society. Now, this was something that was focused on adults. For kids, with our number of 200,000 in the population of the U.S., it's very likely that we can catch a lot of patients with telemedicine. And so I'd like to emphasize our success at Vanderbilt with pairing with our endocrinology colleagues to actually improve access, improve compliance, and to catch these patients at a time in which we can actually educate and hopefully prevent vision loss. All right. Thank you guys for your attention. I'd be happy to take any questions.
How simple is the first step in this, in getting the actual retinal images?
That's a great question. So to be as non-biased as possible, I did not mention the name of the company that we use, but there's definitely different companies that have a setup for as far as the camera goes. But I would recommend one that's pretty foolproof. And so the main thing I think is educating your team and actually having something that takes good photos. So not just any old camera will do it, right? And so the setup that we had was using a camera that was specifically made to do those non-dilated photos. It was actually very, very simple. It takes a matter of seconds to get the photos. Anyone who can hold still enough to take a regular photo can do it. Just like you have a slit lamp that has a little chin rest and a head bar, that's all they need to do is actually to sit right there, and the machine will actually take over. The nurse hits start, and it'll recognize which eye you're focused on. It'll actually focus in by itself and take the photo once it's actually a clear enough image and go to the next eye. So in the matter of less than a minute, you can actually get those photos done and they're done with their visit. And so it's really that simple. Yes?
That was fascinating and something that we'd be really interested in our diabetes clinic. I have a couple specific financial questions. Mm-hmm. First of all, the camera. Who bought the camera? Does that belong to ophthalmology or endocrinology? And then second, patient billing, prior authorization. Mm-hmm. How did you sort that all out?
That's a great question. So the reason why I didn't touch upon that is because we actually used a grant to purchase our camera. So we were in a unique position to offer this to our patients as a starting basis, as something we wanted to see if it was feasible. You know, how easy is it to get these photos? How reliable can we depend on them to do the screening before even going down that pathway of charging? And we were able to luckily get a grant to buy the camera. Many other organizations have worked out differently. We just recently started getting codes to actually code for the actual interpretation to try and make it something that's feasible and can be funded. The success of that, and I've actually spoken to the coders here, they're still working on it. It's not yet done in our system, so it's something that we would have to explore, but it's there and people are using it. And they're using it not just in the ophthalmology clinic or the endocrinology clinic, but also in community partners.
But did you have to determine ahead of time that the patient's insurance would actually cover it? I
That's
just
a great
wonder about the
question.
logistics of that.
In the future, it's possible if we would probably have to figure out what is covered and what is not, and that's why I'm speaking with the coders, because I agree that's a big issue, and we don't want to have something that we don't understand what the financial cost is to patients. We were able to get away with it because it was grant-based, and the ophthalmologist who was reading it did not bill, so that's why it was not an issue. Yeah.
Thank you for that. I'm wondering how often you came up with something unexpected.
Oh, that's a great question. We did. Not everything that came back abnormal was diabetic retinopathy. I would say out of all the abnormals that we had about 2 that were very much so unexpected, and maybe we weren't sure if it was artifact from the camera, one of those few times that you see something that just doesn't look right. But it's actually pretty rare. Most of the kids who had this, they really fell in line with what we were expecting. So diabetic retinopathy in a kid who's 20 at this point has had it since 14 months of age. We weren't surprised to find something, but that was very surprising to find it that severe.
So I have a couple of, sorry to go back to the finances, but
no, absolutely.
So how much did that camera actually cost?
That's a good question. So there's all different kinds of cameras. That one there, I believe, was about $5,000.
Okay, and how often did it have issues where like it wasn't working?
None, never.
Okay.
That's a great question. So the reason why it was purchased was because it was the one that was the most foolproof, the most unlikely to have any issues, and the most longevity. And it was purchased with grant money, so that helps always.
Because I used to work at another organization in town that sees children, and they had, by the Lions, I think it was the Lions, they had one in their clinic in Minneapolis and one in St. Paul, and it was always like down, like whenever we needed it. But it sounds like the technology has improved.
And that's the other thing, is that actually we just had our annual meeting, like I was saying, and I went to go speak with the representatives from the company that we've used before and said, hey, what is going on with the cameras at this point? And they said that model is no longer even available because we've gotten so much better, and it's still about the same price point.
And then the other thing too is I feel like as diabetes care, people don't really want to come to the city. They want to go, they want to be in Maple Grove, they want to be in Woodbury, they want to be in Burnsville. So, I mean, it seems like that's something that we could replicate throughout the system at not an extremely expensive cost.
Yes, and so that's the goal, is to actually go to the people. I think that's the model for a lot of our care now, is we're trying to increase our satellite access. But when you're talking about setting something up that you don't need an advanced provider to actually be working, and that does not break down all the time, and that is actually something that you can read remotely, it's improving care, because we are a tertiary organization. I agree. People don't want to come that far, and we're a big catchment area. So I agree. I think there's a big potential, and the more you can actually replicate this on a larger scale. This one, as I said, was a pilot program under a grant. So we did it in one center in our main university site for our endocrinology clinic. But the way that we found success, if you look at the literature, is actually not only if you do it at the main site, but you can actually go all around. And that's a really great point.
Thank you very much for the presentation. My question for you is about relationship between symptoms that someone might experience in different the stage of retinopathy that they might be at. And then the secondary part of that is at what stages that you're able to start providing some sources of therapy, laser therapy, other things for that population that do have evidence for retinopathy, either at an earlier stage or later stage.
That's fantastic. Do you have an interest in eyes? Because we can talk. But, sorry, you were going to say?
I'm one of the endocrinologists, so I think
fantastic.
just providing this information to patients because...
And so that way they're educated on it. I
Right.
agree. And so something I didn't touch on because it wasn't integral to this program, but the reason why I snuck that VA thing from 2015 in is because they not only did the actual screening that we did, but they used it for education as well. And so they actually had nurses calling into patients and things like that. It was a much broader program than this one was. But the question that you asked, first of all, to address it, was what kind of symptoms. Unfortunately, unlike the cataract or the blurred vision from acute onset nearsightedness, when we get those lenses actually swelling, you can be completely asymptomatic. You can be 20/20 and have diabetic retinopathy. Those would be the early stages where you're just seeing those little focal areas of hemorrhage in the retina, and that's why the screening exams are so vital. It's not only because kids are young and they can't necessarily tell us what they're seeing. It's the same screening guidelines for adults as well, because you can have no signs of it and have the earliest stages. The point at which we actually start treatment, we wait until there's actually either a drop in vision due to it, and that has to be shown to be due to the diabetic changes. So when you see swelling in the retina, when you have leaky vessels to that point, we can start offering things such as laser and the injection therapy. And those can actually be life-changing. Now, that doesn't mean that they're committed to a lifelong course of treatment, but if it's severe, it is something that can actually escalate to the point that we saw with our 20-year-old, where it's almost too late. When we start seeing those traction on the retina, it's because they didn't get laser and injections in a timely fashion to prevent that. Some patients will have excellent control after they start getting treatment, and then they'll relapse and continue to need care. Usually it's a short course, but it feels long because it might be months that they need acute treatment if it's severe. But in the long term, better control of their diabetes can actually prevent the need for laser treatment. Not in kids, but in adults, it's actually been studied. And by decreasing your A1C by 1% in adults, the risk of needing laser therapy, which used to be the only thing that was offered, was reduced by 40%. And while we actually see that long-term care and control can actually prevent the need for intervention and can improve vision, in the short term, interestingly, it can actually get worse. So really working closely with you guys is really important, because if we're picking up on diabetic retinopathy and then they're motivated to get better control, we want to be seeing them to make sure this isn't getting worse in the short term. I oftentimes tell patients that we see a lag. What you do today will really benefit you in 2 years' time, in 1 year's time, things like that. And so you're really paying forward into your future with kids. It's really vital for them to understand that they're paying this forward for their next 20 years, their next 40, 50, 60 years. So.
Thank you, Sasha, and welcome.
Thank you.
I was wondering if you would comment for the rest of us who don't take care of patients with diabetes every day. What are the potential other uses for this? And I'm thinking in particular of the fact that I'm a neonatologist, and we participated in a study looking at using something similar to this to evaluate kids with retinopathy of prematurity, because obviously that disease sort of peaks at the time of discharge from the NICU. So what are some other potential ways you can use this technology?
Well, it's really exciting because what we were talking about before about people being outside of the cities area where we are to actually screen in person, especially when we're talking about neonatology. A lot of places are going towards telemedicine to try and provide in rural areas. Or even not. Some places are actually doing it remotely because they find that that works for their program. So retinopathy of prematurity is definitely a possibility for the future. It's not as well established as diabetic retinopathy. Obviously, there's no adult model to try it on first, and people are always a little bit scared, as I'm sure you know as a neonatologist. People are always scared to try something new in premature babies, especially with something that's a blinding disease. But it can work, and it can do a good job. It's not the same as this, though. This is somebody who does not need to be an advanced care practitioner, does not need to be an ophthalmic photographer. In order to properly get good photos for something like prematurity, retinopathy of prematurity, you actually have to have somebody who's an ophthalmic photographer who's very well trained in order to get the photos. These are actually just the center part of the posterior pole, which includes the optic nerve and the macula and those vessels associated with it. With retinopathy of prematurity, as you know, and for those who don't, it's actually affecting the very edges of the eye. So the wallpaper of the eye, the retina that goes all the way out to the edges is where we normally see it. When it's very bad disease, we see it in the center right there, and that's pretty obvious, but you need to have somebody who's actually able to get the camera to go all the way out there. And it's a contact camera. It does require that you use a coupling jelly. It carries the small but important risk of having a scratch on the eye if somebody doesn't do it right. I've never seen that, but it's something important to know. So it's a little bit different, and it's got a lot more nuances and preparation, but it's doable, and people do it. The other thing that we see is people are actually doing this for glaucoma, which is fascinating because a lot of specialists will tell you glaucoma is not just one thing, right? It's not just one photo, but it is being used to try and help with people who are not able to come into clinic to try and at least get some screening and see if there's anything obvious and apparent. Those are really the three biggest applications I'm seeing it right now in ophthalmology. I'm sure there's more.
Thanks very much. Sort of a follow-up to that one, and that's about the ability of technology like this to spread and to improve access to other populations. You mentioned that even not just in rural places, but in perhaps urban locations, there's this opportunity. Do you think that that's worthy of pursuit? So should primary care clinics be developing the ability to do something like this for populations that might not otherwise follow up with the subspecialists I'm thinking about because of a socioeconomic status or resources, and whether this is a reasonable alternative?
Yeah, and so I think that's a great question. On my wish list, I have a lot of things for what I wish that we were able to do, both in the ophthalmology clinic and in our primary care colleagues. I wish that there was more spot vision type vision screening, not just for diabetic retinopathy, but for actually using photo screeners to look for things like amblyopia, pupil size difference, strabismus, things like that. So that might be first on my wish list, and then second would probably be this. But I think it's also in knowing your population. If you're seeing a lot of high-risk youths who are not compliant and who are not well-controlled, then this would definitely be something that I would say I would push for, potentially. But the thing is that you have to know the population, and you have to have a motivated and well-supported system. Some of the drawbacks of having a telemedicine screening thing is not just financially working that out, which can be worked out and set up, but once you have that is also figuring out how far you're going to expand and how much you can support as a system. And so making sure you have the support there, not just to screen and say this is abnormal, but actually refer and get patients in is really vital. And so it's really more about finding out in your community, is there somebody who will help take on those patients, I think would be number one. And that's what we're here to do, is to try and help with that access as well.
Thank you.
It's just a follow-up on something other people have raised, but are you, as an ophthalmologist, able to bill for looking at these pictures? Because that seems like it'll kill it in its tracks if you're not.
If it's, I'm sorry?
If you can't, then it would seem like it has limited range.
So theoretically, yes, you are able to. I can't speak from personal experience. I can tell you that other programs have been able to bill for it. Which insurances are covered and which ones are not, especially in kids, I don't think is as well parsed out, and that's why I would love to learn more from our billing centers and the ones around the country. But it is something that you can bill for. And that's what the key, I think, as well, to making a sustainable support network, is to make sure that people feel that it's something that's worthwhile and that they're actually able to support clinically. Because you can't have a program that's grant-based everywhere. You need to have something that can actually keep the lights on and keep the cameras up to date.
Thank you for an interesting talk. Does it require documentation of training by the nurses that take the photos?
We did not have documentation of the training of the nurses. The photos, we did not find any problems with that. As far as legal questions and medical legal issues, in the literature at least, the biggest things that are raised are whether or not you can actually read photos if you're not a provider in that state. So as you know, we're a catchment area for Dakotas. Could we actually read over there? You'd have to be licensed over there. Those are the more medical legal issues that I've seen. The photos are actually under the auspice of the reading provider, as far as I'm aware of. I'd be surprised to hear something otherwise. If there was a lack of ability to get a photo, it would be on the provider who had ordered it to make sure that they either have that follow-up screening or that the recommendation is well documented to actually get that done, if you're asking from the medical legal standpoint.
And does the camera require a yearly service contract?
That's a great question. I'm not aware of ours needing that. From the ones that I've recently spoken to them, the biggest thing is the determination of whether or not you need to have a software to send it over to your electronic health record system. Currently, the most up-to-date technology, you don't, so I don't expect that it would necessarily need that.
Thank you.
So I guess my question is, are you trying to replicate something like this here? And if so, that would be wonderful. And how do we get that rolled out? So, in this system, we're talking about 20 grand. We've got 4 locations at C Diabetes. Our Peds Diabetes program, we have wonderful educators. So, I'm fairly certain that we can get everybody done if we have the cameras there. So who buys the cameras, right? Yeah. And then we probably should go directly to Blue Cross Blue Shield in Minnesota, for example, who insures 40% of the state. It seems like that would be something they would love to do, because that's going to save them money in the long run. The patients are going to be thrilled because anyone who's been to the pediatric or adult ophthalmologist knows you sit there for many hours.
We're working on that.
Well, it's not your fault, but I'm just saying that's how it goes, right?
Yeah, so I agree. As a patient, I understand wait times are one of the biggest things. And I think it's a win-win, and that's why I'm presenting on it today. I've only been here for a month and a half, but luckily, before coming here, the conversation, I believe, was already started with our endocrinology colleagues about what we can do to actually screen. And that's why I'm presenting this today, is because not only is it an interest of mine, but I'd love getting the feedback from you all and see what the interest is and see where we can take the next conversation. Because it really needs to be a group discussion. The best way that we were able to establish this was as that collaboration between endocrinology and peds. And as some people have mentioned, maybe even primary care. But as a start, I agree 100%. We need to start thinking about how we can implement this. And it's good to hear the recommendation about going to Blue Cross and Blue Shield to see what they would be able to work with us on. And I 100% agree. And so if afterwards, if guys, anybody who's interested in being a part of that discussion, I'd love to talk.
And then the other thing is too, I'd love to get some data from here about what actually is, how much pediatric diabetic retinopathy is there. I mean,
Yes.
I've been in practice for about 10 years. I'm not sure about my partners. I've actually seen very little.
Yep.
I think one of the things from the older data, like the study out of Wisconsin that was published in 2008, I mean, that's looking back, 25, 30 years.
Yeah.
And, 30 years ago, you were dealing with regular and NPH twice a day. Now you are dealing with almost fully automated systems that keep blood sugars near normal. And I would love to see the more recent and current data, because I was actually a little saddened to see the high percentages that you found.
Yes, and so that's why we actually did the grant program over at Vanderbilt, was to see what the need was. Now that's a very different clinic population, as you saw from the map from the CDC about just general prevalence and incidence by state. Minnesota is not one of the high states. So we're very lucky. We're not Mississippi. Our obesity rate is increasing in children, but we're not at the levels in which we are seeing what I probably saw in Tennessee. But I can't tell you for sure. I can tell you one of the reasons why we did this study itself and looking at the difference between the two groups, especially things like compliance, even though we didn't find that there. You might argue that might be because it was a small sample size or whatnot, was because anecdotally over in the eye clinic, we were saying, we don't think we're getting the patients who are poorly controlled. We don't think there's compliance with screening eye exams. And so maybe the incidence is falsely low because the patients who are motivated to come to us have parents who do give them the great teaching and the great education from you guys. They actually take home and apply it to their home care. And so we felt that we were falsely seeing that. Studying that was a little bit hard. I'll tell you anecdotally, yesterday I was supposed to see a diabetic patient who I have to send a no-show letter to because they didn't show up. And so that's anecdotally what I see a lot of. And I worry about those patients a lot more. And I wonder if we had the screening program here, if we'd be able to catch that patient, educate them right away and say, hey, you've got something here. Let me show you what the photos look like. Let me tell you that right now this is a great time to go over to the ophthalmologist. Let's get you in the next month and let's go from there. And so, yeah, I agree. Anything else? I could talk about this all day. As much as I need to go to my clinic in Burnsville, I could do this all day. Thank you guys so much for your attention. Like I said, if anybody, I know I've got a lot of people to meet who I haven't met here at the institution just yet, and I'd love to meet you all, but if anybody has any specific requests for meetings and things like that to start the conversation, like I said about this, I'd love that. So I'll be up here. Okay, thanks guys.
You have been disconnected from the meeting.